Good afternoon, and thank you all for joining us. My name is Sarah Buchanan, and I'm the Director of Advocacy with the Crohn's and Colitis Foundation of America. Our purpose today is to have a robust discussion regarding the patient protections in Connecticut, which have been passed into law over the last few years. Should you have any questions for our panelists, please submit them in the chat section. Our panelists today are Dr. Robert Schoen. Dr. Schoen practices rheumatology at New Haven Rheumatology PC and is a clinical professor of medicine and nursing at Yale University School of Medicine. Dr. Schoen graduated from Harvard College, magna cum laude, and obtained his medical degree from Columbia University. He completed a research fellowship in rheumatology at Brigham and Women's Hospital / Harvard Medical School. Dr. Schoen also obtained an MBA from the University of Connecticut. Dr. Schoen is a frequently invited lecturer on rheumatology subjects and is the author of approximately 100 scientific publications, many on Lyme disease and other infectious arthritis diseases. Dr. Schoen is currently the president of the Connection Rheumatology Association. We also have Patrick Stone. Patrick is the Associate Director of State Government Relations at the National Psoriasis Foundation. The National Psoriasis Foundation is the leading patient organization for the 8.3 million Americans living with psoriasis and psoriatic arthritis. Before we begin, I think it would be helpful to give an overview regarding what step therapy is. Step therapy is when an insurer requires a patient to fail first on as many as 4 different medications not prescribed to them by their doctor before receiving the originally prescribed medication. The use of step therapy is increasing steadily. In 2010, nearly 60% of commercial insurers were using step therapy. As of 2013, 75% of large employers reported offering employees plans that utilize step therapy. The perspective of insurers is that step therapy helps to lower health care costs while maintaining or possibly improving the quality of care. In some cases, step therapy has played a role in achieving these outcomes, but in other situations, data clearly shows that step therapy can have the opposite impact. Step therapy can delay or lower the quality of care. Since step therapy requires patients to try one or several medications before being covered for the drug selected by their healthcare provider, it can delay access to the best therapy. In the course of these delays, patients may experience disease progression, a serious risk for anyone living with a debilitating or life-threatening illness. 48% of patients in a recent study were denied approval to their medication. 52% of those patients ultimately failed to receive their original prescription. That process exceeded 90 days in many instances. Step therapy can also lead to increases in costs. In a study comparing spending on schizophrenia medication in Georgia's Medicaid program, step therapy saved the state $19.62 per member per month in atypical antipsychotic expenditures. However, these savings were accompanied by a $31.59 per member per month increase in expenditures for outpatient services. As a result, step therapy did not have the intended effect of reducing overall costs. Rather, it increased healthcare costs. Similar findings have been observed when step therapy was applied to blood pressure medications. In California, where an independent medical review of a benefit decision can be conducted in conjunction with the state and the insurance company, 64% of all decisions made by an insurance company were reversed by the independent organization. Only 28% of the insurance company decisions were upheld. Step therapy is applied to drugs treating a wide range of diseases and chronic conditions, including Alzheimer's disease, autoimmune and inflammatory diseases like Crohn's disease and ulcerative colitis, cancer, diabetes, epilepsy, glaucoma, hemophilia, HIV/AIDS, liver diseases, mental health, and psoriasis. So step therapy does impact many people in the nation. With that, I'll hand it to Patrick Stone of the Psoriasis Foundation, who will talk about the specific protections that have been passed into law in Connecticut.
Thanks a lot, Sarah, and thank you to Sarah for moderating our discussion today and for Dr. Schoen for also participating in this discussion. You know, as Sarah outlined, step therapy is something that affects not only people with psoriasis or Crohn's, but really everyone that's living with a chronic disease, and many people that are just simply trying to get a prescription filled. So we're excited about the protections that are in place, not only in Connecticut, but in other states across the country. And we'll focus today a little bit about Connecticut And I should also add that this webinar is the first in a series of webinars that will be state-specific regarding step therapy protections. So in Connecticut, the protections have provided a greater pathway for a provider or doctor to gain an exception to step therapy protocols. The protections impact both the commercial and Medicaid space, and I think that's important to note, and there's differences in between the protections. For commercially insured patients in Connecticut, step therapy can be overridden in any therapeutic area after 60 days based on a law passed in 2015. That law is State Law number 394. This law limits the amount of time an insurer can force a patient to fail on a forced medication. And what that means is the patient has gone, spoken with their doctor about what is going to be the most efficacious treatment for their particular condition, and the insurer has said you must first fail on this other medication first. So in this instance, in the commercial space, that limits the amount of time an insurer can force a patient to fail on a forced medication before reaching the originally prescribed medication. For Medicaid patients, step therapy can be overridden in any therapeutic area after 30 days rather than 60. This is according to State Law Chapter 319V, Section 17B-274F. And we list that out specifically because we are hoping that providers will cite that law on appeal letters when they submit them in order to gain a better chance of getting an expedited appeal. Additionally, a patient can be forced to try and fail only one drug on the preferred list before another can be prescribed in the Medicaid space. For both commercial and Medicaid plans, both these allow overrides of step therapy protocols if the following conditions are met. One, the mandated treatment has been ineffective in treating the patient's medical condition in the past. Two, it is expected to be ineffective based on the known characteristics of the patient and the drug regimen, and will cause or will likely cause an adverse reaction. And three, it's not in the best interest of the patient based on medical necessity. We believe that these protections lay a good groundwork for an appeal to step therapy in the state of Connecticut. And with that, I'll turn it back to our moderator.
Thanks, Patrick. I do think it's important to note that while these protections don't eliminate the practice of step therapy, they do provide protections for patients by making sure that patients can access an exceptions process, and that's important. So let's hear from the physician's perspective on the implementation of these protections. Dr. Schoen, as a rheumatologist, can you provide us your perspective on how step therapy affects your practice and the treatment of your patients?
Sarah, Patrick, thanks for having me to be part of this web program. This has definitely had a big impact on the practice of medicine for rheumatologists, and I suspect all physicians, because there certainly have been advances in my 25-year career in which we have available many new, exciting, and expensive therapies. So I fully understand the need to contain costs as a general rule. On the other hand, the step therapy approach comes at this like I don't know, if you're weeding your garden and you may pull out weeds, but you don't want to pull out the plants themselves. And so I think there is potentially for proponents of step therapy a cost argument. I really don't see any quality argument. That is to say, in my experience, sometimes step therapy is not onerous. Sometimes my incentives are aligned with the insurance company, but sometimes they're not. So step therapy has had a big impact, and I'm not sure it's the way to go, but it's certainly here for the present time. So this law in Connecticut, where I practice, does provide some help, some information, some legal context in which this problem exists that has the potential to help me as well. When when I see patients, as I've said, it's likely that I will need expensive therapies for many of my patients where I think a lot of the step efforts are directed. Many of these therapies for diseases like lupus and rheumatoid arthritis, for example, the therapies take some time to work. So often I'm in a hurry, perhaps the patient is in an even bigger hurry to try to get relief for their problem. So I want to move things forward. I know that it's going to take time for me to get treatment approved. I know that for many of the drugs I use, it's going to take time for the treatment to work. So I will prescribe what I think is in the best interests of the patients. As I've said, sometimes it's aligned with the step therapy process. Sometimes it's not aligned with the step therapy process. Sometimes I can live with what I'm being asked to use. Sometimes I really feel like I can't live with what I'm being asked to use, and I'll make my decisions accordingly. So in spite of this legislation, I still see a situation in which I need to make a determination about what I think is necessary, and then make a determination about what I think I'm going to do based on what I'm being offered by the patient's insured. And I still look at the process as one in which I may have to therefore appeal. Now, having said that, where I think this legislation has helped me, where I've increasingly using it, is that I want to bring this legislation into the discussion, if you will, that I'm having with the insurance company about whether they will or won't provide the therapy that I think is in the patient's best interests. So I'm presenting myself as an informed physician. I know my rights, if you will. The truth is, I don't think the legislation has a lot of punishments for failure on the part of the insurances, so I still come with an appeal justifying what I need to do to get my patient a particular therapy. Patrick mentioned, for example, that if it's the physician's judgment that a particular step therapy shouldn't go forward, they can override that. But in order to do that, you still have to appeal this, if you will. And so the same process that I've been doing for some time continues. It hasn't fundamentally changed. But where I think this may give me an edge up is that if I'm appealing a decision, if an insurer doesn't want to allow me to do what I think is medically necessary, then I'm going to use this as a tool, if you will, to help me receive that intervention. So that's kind of where I've been using it, and I think it's a step in the right direction. That's kind of my experience with this.
Great. Do you have a specific example of a recent NPF in which you used the language in these protections to gain a successful determination? I know you mentioned you had said that you typically demonstrate awareness of your rights in seeking NPF.
It's hard to tell because I'm now pretty much using this any time that I appeal, and I don't necessarily use this as the only tool. So, and honestly, I think that if you think about some of the therapies that I might use, let me use rheumatoid arthritis as a general example. In rheumatoid arthritis, if I'm thinking about some of the more expensive therapies, the so-called biologic therapies that have become available and provide a real advance in the treatment of rheumatoid arthritis, these therapies generally compete pretty well with each other in terms of efficacy and safety overall. But they have differences. There's a role for, cars are cars, but an SUV is different than a sports car, and there are times when an SUV is a very good idea, and there are times when a sports car is a very good idea, and there are times when a general sedan works just fine. So to answer your question, the way I think about this is that sometimes the appeal process is easy for me. I see the insurer making what I think is really a completely inappropriate request. An example of that might be I've treated a patient with a drug that works by blocking TNF, which is one of the ways rheumatoid arthritis drugs work. And that patient had an allergic reaction. And then I used, just hypothetically, I used another TNF drug. And the same thing happened. Now, if somebody says to me, use a third one, when I could switch to a different mechanism of action, that makes no sense. In my mind, that's a relatively easy appeal. And there's other examples where the process is pretty straightforward. But in any case, I do use this process of citing the state legislation as part of what I do, and I think it helps me overall.
Great, right. So what I'm hearing is that being aware of these laws facilitates and supports your appeals.
That's correct.
And we see that a lot in the IBD space also, the 2 anti-TNF failure requirements. So that's important. Well, thank you. And Patrick, can you also talk about how this issue is continuing to evolve across the country?
Yeah, and I think I'll just, tee off a little bit of what Dr. Schoen said. We're for most of us in the chronic disease space, we're living in a very innovative time. I, of course, acknowledge that there are many disease states out there that are still seeking treatments to come to market. But for many of us, we're living in a very innovative and exciting time for our patient community. And specialized medicine is important. And oftentimes, formularies ignore that specialized ability for doctors to individually treat patients based on their needs. Specifically in the psoriasis space, as you mentioned, that sports car may be good for somebody, but the SUV may be better for somebody else, right? But they're both cars. So I like that analysis. I like that point. Connecticut was one of the first states in the country to pass a more comprehensive piece of legislation, although this is several pieces of legislation regarding step therapy protections. But the National Psoriasis Foundation, in partnership with groups like CCFA, AAD, the Arthritis Foundation, many other patient and provider groups, of course, the rheumatology organizations across the country have worked on model legislation that passed in 5 states last year, or in the past couple of years, excuse me. These protections are a little bit stronger than here in Connecticut in many instances, and we're excited about the opportunities that they provide for patients to get the best care for their individual needs in those states. I'm sure that you will see, if you're following this legislation, you'll see it introduced in quite a few states this year. We're excited about that. We're also excited about engaging with payers on this issue. One of the things I think that's led to the success of this legislation and has led to the codification of these protections is talking with insurers about what's important to patients. And talking about specialized medicine and individual care. And I do have to give credit to the insurers. They've been receptive to hearing what our concerns are and coming to the negotiation table on this legislation. And I was even happy to see that some insurers had signed up for the webinar today. So we look forward to continuing to partner with both patient provider organizations, pharmaceutical companies, and insurers and PBMs on this issue moving forward.
Absolutely. Thank you. With only a few minutes left, we do have time for questions from participants. So please feel free to write your questions out in the chat box, and we can take a look at those. We do have some questions that were asked earlier in this webinar. We had questions about if any handouts will be available after this event, and it looks like we are happy to provide specific information related to Connecticut, although we don't have a specific handout yet. There's also a question about whether this is being recorded and available after the event. You're taking my talking points away from me. And yes, this event is being recorded, and a link will be sent to all attendees within 48 hours after the event. And those are all the questions I've seen so far. So if there are any further questions, please do write them in the chat box.
And I'll just add to your points there, Sarah. You can visit psoriasis.org/advocacy for further information. And I think that there are some documents available that we can possibly send out. We'll have to look into that. But do feel free to reach out to either Sarah or myself through the recording that will be sent out and the webinar if you have any further questions.
And Patrick, we did get another question. What are the 5 states that have passed step therapy legislation?
So step therapy legislation has passed in Illinois, Indiana, Missouri. It is also passed in California and West Virginia, and I'm probably missing another state there. But those are the states that it's passed in thus far. Now that's our model legislation, and I should add there to the caveat that there are protections in place in a number of states when it comes to either utilization tools or step therapy. But we don't consider them as strong as the states that I mentioned there. You know, and I'll also mention that there's a bill on the governor's desk in New York. So if you've got friends in New York, we're looking for advocates to support that effort there and get that bill across the finish line in New York. It's currently awaiting Governor Cuomo's signature. So there are protections in other states that allow for an appeal process or an exception process, but we're looking to strengthen those state by state.
I'm seeing questions that are asking about how the bills are different. I know you've gone over it in your last response, but would you mind just itemizing that one more time?
Yeah, and I failed to mention Kansas as well. Kansas is the last state. And unfortunately, I should mention that the West Virginia bill was, through a technical procedure, made null and void recently, so we're going to have to rerun that bill, but it did pass there. The difference is, you know, I think we don't have enough time to go into probably about another half-an-hour webinar on the differences in between the language in, say, Illinois versus Indiana. But what we do is we go in with, we have 5 exceptions that we've written out, and we believe that these exceptions to step therapy cover a wide variety of disease states and really will help a number of patients out. So we go in with a very strong bill, and then we adjust that bill based on the needs of the state, right, and current protections that may be codified in the state already. The important thing to note is that in the states where our, quote, model legislation has passed, we believe in each one of those instances there's a strong enough bill that has passed that if you have a, you know, medical necessity that should that would cause you to be able to override your step therapy protocol that you're being asked to do, you'll be able to do so based on the protections that we have passed.
Okay. I do have a couple more questions, and I think we have time for these. The first is, do some insurers require the use of opioids before other drugs for pain treatment under step therapy?
And I'm pulling
Not familiar.
I'm pulling a Donald Trump here and going for my water. You know, I'm not very versed in opioid laws and how they're impacted by step therapy. I think if you can submit that question in writing, I know that some of our friends from U.S. Pain Foundation are on the webinar, and we'd be happy to pass those along to them.
And then I also see another question, which is more of a comment that several other states are considering step therapy legislation. This is true, including Ohio and North Carolina, in case anyone is interested in following the progress of those bills. So thank you for that comment. And then, you know, Patrick, what is the bottom line that you would tell patients now about what they can do if a step therapy bill is passed in their state?
You know, well, I'll say 2 things. One, for the states that we're looking to run step therapy bills in, you know, reach out to whomever you're affiliated with. You know, if you're an arthritis foundation volunteer or a psoriasis or a CCFA volunteer, reach out to your respective people and talk to them about volunteering and getting involved in the advocacy efforts and talking to your elected officials, right? In states where the bills have passed, talk to your physician. You know, if you're subjected to step therapy, say, I'm cognizant of this law. I'm sure you are too, right? Let's work together to cite the law in an appeal, understand your rights, and if you or your physician don't have a good understanding of what the patient protections are, again, feel free to reach out to any of us and we can explain them to you and guide you on that path. And if you're a psoriasis patient, and I'm trying as hard as I can to keep this as broad as possible, but if you're a psoriasis patient, you can visit our navigation center. You can go to our website. and visit our navigation center or call the navigation center and speak to someone. They're standing by to talk to you about these protections in different states and about treating your psoriasis. I think it's a great time. It's unfortunate, of course, always to have a chronic disease, but there are so many resources that are available and so many organizations out there that are willing to help you.
Absolutely. I think that's a great point to volunteer in your state if they're considering the bill. Talk with your physician about it if you're subjected to step therapy, and then also reaching out to your affiliated foundations. Several foundations have similar navigation centers. For CCFA, it's our IBD Help Center, which we have on hand for patients that need to find answers to those questions. It's a good answer. So thank you to both Patrick and Dr. Schoen for being with us today and providing all of this information. If our participants would like more information about this issue or you would like to get involved, please contact me or Patrick. An archived version of the webinar will be housed on the National Psoriasis website and will be distributed to all registrants. We also ask that at the end of this you take a survey which you will be prompted to do at the conclusion of the webinar. This is helpful for us so that we can improve our future webinars. And thanks again for everyone's time today, and that concludes our educational webinar on step therapy. Thanks.
Thank you.